Good evening, everyone. I, Dr. Manisha Bis, welcome you all to today's session of Faculty Guidance Webinar on COVID-19 Crisis Management. Today's session will be taken by two speakers, Dr. Amit Tyagi from the Department of ENT and Dr. Biswajit Sahu from the Department of Microbiology. They will be talking about a very relevant issue in the present scenario of COVID management. They will be talking about a multidisciplinary approach to mucormycosis in COVID patients. First, I will invite Dr. Amit Tyagi to start his presentation, and then he can hand over it to Dr. Biswajit Sahu. Dr. Amit, I think you can take over.
Am I audible, ma'am? Am I audible? Am I audible?
Yes, you are audible. Please, you can start now.
So, a very good evening to all respected senior colleague and dear good friends. Today the topic, actually, as we are all aware that in recent surge of mucormycosis in present COVID pandemic, and we have been seeing it's increasing day by day. So today, and we all are aware that it's very lethal effects on body and it's worse morbidity and mortality. So we can say it seems that it is going to increase in couple of days also, and that's why I just start with saying this. It's a diagnosis we cannot afford to miss. So for the next few slides, I would be taking you all through in these steps. First, I would be discussing about status at AIIMS Rishikesh, and why we need to know about the disease, which will help in treating it, why it is the need of the hour, what are the risk factors, what are the clinical features, what is the diagnosis, what is the treatment, and how will we prevent it. So first, starting with the status at AIIMS Rishikesh, this is yesterday data, and at present we have around, yesterday we had 42 patients, and the point which I would like to re-emphasize here that diabetes mellitus patients, all patients are having diabetes. So this is one of the main thing which we are finding, that all patients who are coming to us with mucormycosis, all are having diabetes mellitus. On history, they all have, only one patient is COVID negative. However, all 41 patients, all other 41 patients, they have either history of COVID positive, or they are coming with active COVID. And however, in-house mucor, we decided to choose this definition as the person who has admitted here with COVID negative status or COVID positive status, but after 5 days of treatment here, developed mucormycosis. So we have found these kind of patients, only 3 patients here. So it shows our robust steroid policy and proper management also. If we see this slide, we can see from 29th of April, we have been getting these patients 4 or 5 daily. And till 14th, we had around 5 patients. And after 14 daily, we are getting around 8 to 9 patients daily. And at present, we are having around more than 50, around 52 patients. So that is another thing. That other thing is, because once these patients are admitted, they have to be with us at least for 2 weeks. So it is going to be huge burden on us, that how we are going to manage such a large number of patients. So why this mucormycosis surge in present pandemic? So in pre-COVID period also, we have been seeing this condition in poorly controlled diabetics, immunosuppressed patient, and hematological disorders. However, in COVID period, the probable reasons we are seeing more patients, maybe because of the high dose steroid therapy for COVID-19 disease, not only in diabetics, but in pre-diabetics also. Most of the patients we have found that they were pre-diabetic and they were started on steroid therapy, and not only started in first week of steroid therapy with longer duration, higher doses, and they developed this mucormycosis. The another reason might be because of the indiscriminate use of potent antibiotics, and a few articles and few evidence are also available on the after the developing mucormycosis after use of monoclonal antibodies. So let's meet this protagonist of this misery. So this is a very fragile fungi actually, but it is ubiquitous. So some used to say it's a fungus of paradox, it's a parasite, but actually it's ubiquitous. It's in the air, more than air, it's in the soil. It's usually found over the dust particles, soil, or over the decaying organic matters. It may be leaves litter, it may be compost, it may be any excreta. So these are all things which this mucor actually we can find. Now, these hyphae are broad, which is 5 to 15 micron diameter, and it is actually more in broad than aspergillus. It is irregularly branched and have rare septation, and it's very fragile. One more thing, it is actually colorless. It's not a black fungus. It is a colorless. However, because it causes black skin, necrose skin, so probably that is the reason why in media we are seeing it's a black fungus. So these are some of the articles which mention that mucorales could be cultured from 47% of hospital linen at several cancer and transplant centers. So this is one of the reasons which we also need to look into our hospitals, that we need to focus on hospital linens. So portal of entry included surgery, catheter, especially intravascular catheters and adhesive tapes, adhesive bandages, even wooden tongue depressor. There is a one very large series over this where they found that because of this wooden tongue depressor, they developed GI mucormycosis. Adjacent building construction is one of the risk factor, and obviously hospital linens as discussed. There's a one report of fetal GI mucormycosis has also been reported in a premature neonate who receives a probiotic. So let's come to the pathogenesis, which is very important to understand. So once we know this pathogenesis, I think a lot of things can be understood in context of treating this disease. So here, this we can see the normal host and or B is susceptible host. So there are three mechanisms by which this mucor break the innate immune response. Number one is it actually sequester the iron from the iron binding proteins, and it is fond of iron for its growth. So first is it's remove the iron from iron binding proteins. Number one means it's not causing, but it is important for its growth. So this is one sequestration, number one, and it's one thing is it's evade the whole phagocyte mechanism. So this is the immune response which is responsible for its growth. So number one is free iron. Number two is as it's escaping of the normal human phagocyte defense mechanism. The other thing is it damages the endothelial and then enters into the blood vessel and it causes necrosis. So here we can see the 1, 2A and 2B. So one is this is the innate immune defense mechanism. So this is a iron sequestrating protein which binds the free iron. So this is a very important. So this iron should be attached and fixed to the iron binding protein. If it is loose, this is beneficial for this fungus. The neutrophil, which is also because of its phagocytic action, it acts against mucormycosis. And tissue macrophage, obviously, again in by the same mechanism. And endothelial, because of its integrity, they also prevents its entry into the blood vessels. Now, what happens usually in susceptible host? So, as in diabetic ketoacidosis, in acidosis, this iron is released from its iron binding proteins. So first thing happens, this iron comes out, and it's very interesting also one more thing, that in COVID, this virus acts on hemoglobin and it releases iron from hemoglobin and porphyrin. So this iron from hemoglobin also it releases, which is also beneficial for the fungus. So COVID pathology, maybe this is one of the reasons also that we are finding this fungus more associated with COVID, because COVID also break the hemoglobin and releases the iron in serum. And acidosis, like diabetic ketoacidosis, also do that. So which is beneficial for fungal growth. The other thing is the neutrophil, either neutropenia or neutrophil dysfunction by steroid or by diabetes can cause dysfunction of neutrophil, and it leads to the dysregulation of phagocytosis. So then it evades from this defense mechanism also, and then it causes endothelial damage also, and it enters into the blood vessels and cause thrombosis and further necrosis. So the pathogenesis at the end, it leads to angio invasion of mucorales and its spores, It forms a thrombus inside that, and it further causes tissue infarction and progressive necrosis of associated heart, short pellet, eye, and it goes intracranially also. So if we see this worldwide distribution of mucormycosis, we can see India, it is around 0.05 to 0.19 per million population, but it is pre-COVID era. So we need to see what would be the incidence and prevalence post-COVID. So if we after this, with this pathogenesis, we can understand the risk factors also. So the risk factors are case of concurrent and recently treated severe COVID-19, that is within 6 weeks. So that is one of the risk factor now. Uncontrolled diabetes mellitus and other diseases in which immunity is lower, like HIV and AIDS and primary immunodeficiency states. Use of immunosuppression by steroids, tocilizumab and other immunomodulator, prolonged neutropenia, prolonged ICU stay, post-transplant malignancy patient, trauma, burns, IV drug abusers. Voriconazole therapy means this is another thing. Most of the ICU, this prophylactically, some ICUs I have heard is that they usually start voriconazole therapy, and actually it is good against aspergillus, but it actually give an environment where mucor actually grows. Deforuxamine and other iron overloading therapy. Contaminated adhesive bandages, wooden tongue depressor, adjacent building construction which cause a lot of dust, and hospital linens which are soiled are also a risk factor. So there are multiple types of mucormycosis, but I'm going to focus here on rhino-orbitocerebral mucormycosis, which is we are getting only these type of cases. So the symptoms are nasal stuffiness, foul smell, nasal discharge, unilateral facial edema, diplopia, proptosis, loss of vision, restriction of eye movements, palatal or palpebral fistula, blackish discoloration over the bridge of nose, headache, toothache, loosening of teeth, jaw involvement, and altered mental status. So any of these symptoms and signs, if we see, definitely we need to, this is an alarm that we need to diagnose it early. Coming to the investigation, lab parameters, we are all aware. I will not go into this. The diagnostic nasal endoscopy, I am going to discuss it shortly. It is the diagnostic nasal endoscopy is not only important for early diagnosis. Again, I am just saying early diagnosis, but also it is also important that any KOH swab should be taken with the assistance of diagnostic nasal endoscopy. No swab and no tissue should be taken without diagnostic nasal endoscopy. Imaging, CECT nose and PNS, CI and CE, MRI, brain, orbit, and face should also be done. And this also I will discuss it shortly. So a lot of literature, they just recommend that early detection is the key. So that is important, and how endoscopy help in this. So coming to this, so nasal endoscopy, it's because invasive fungal sinusitis usually starts in nasal cavity and spreads to deeper structure of sinus, orbit, and cranial wall. So the identification of the mucosal changes, it's the most consistent and specific clinical finding in IFS. So most of the articles are saying it is the most consistent and specific clinical finding in IFS. So I'm emphasizing it again. However, the site of sinonasal involvement is variable. These are the descriptors which we need to notice, like crusting, debris, scabbing, eschar, granulation, discolored mucosa, decreased bleeding, and insensate mucosa. The last 2 points are very important. So if nasal mucosa is not bleeding and patient is not feeling any pain, it is probably you're dealing with a mucor. Here we can see this is bulla ethmoidalis. This is middle turbinate. This is septum inferior turbinate. Like you can see this normal mucosa. However, on the other side, if you see this side, you can see the black crust, you can see the white or pale mucosa, which is actually a necrose, early ischemic changes. You can see again necrose mucosa, and this is whole necrose septum. So this is the features which we usually see in endoscopy. So that's why it is said that we should always do endoscopy. It is, and simultaneously at the same time, we need to do the sand for KOH staining as well as for biopsy and fungal culture, which will be dealt by Dr. Bishwajit after my presentation. So these are some of the patients where this imaging I would like to show some important features. Like this is one of the patient where eye and the nose are involved, and we can see, but this sphenoid and the ethmoid sinus are involved. We can see the mucosal thickening in this area, and it should be correlated with the clinical feature. So it's nothing else than mucor. So in this patient same, we can see the MRI, and this you can see the hyperintense lesion involving the sinus, but it's not going into the orbit. Here we can see this lesion. Again, this is a picture of this. This patient has palatal fistula also, and we can see this lesion is going into, actually is going into the orbit. So this is an intraorbital lesion also. And here we can see here, this is actually has gone into intracranially. So this imaging endoscopy is important for your early diagnosis, and so imaging is important to correlate your findings and for making a plan that what surgery you are going to do. So it is important to consider all these things in context of, as well, obviously with history and clinical examination. This is one of the picture where you can see the, actually it has caused, initially it is started with the carotid vasculitis, and then later it caused thrombosis of internal carotid artery. So it is, and it's within 1 or 2 days it happened. Now, as we see that gradually that it has been coming, that third peak would be with the children. So I just find one, this is the earliest and the warning sign of a potentially fatal invasive fungal sinusitis in immunocompromised children. So that is, we need to also take care of this, that in any child, if we see nasal discharge, ENT consultation should be sought for that. So how are we going to treat it? So we just, with a clinical diagnosis, either it's a possible or it's a proven for urgent surgical debridement. Obviously, the strict glycemic control is the key for management, and injection amphotericin B should be started if you are it's a highly suspicious of mucor, and we should not wait for any QH staining, and we should start injection amphotericin B, as well as we need to do the urgent surgical treatment. So again, I am emphasizing early diagnosis and early treatment is the only key to save the patient. Again, after this, we should continue the treatment till resolution of initially indicative findings on imaging and reconstitution of host immune system. There's second line, other than, because amphotericin is the only drug of choice, but the second line azole derivatives are also available for step down or salvage therapy. Like posaconazole is broad spectrum azole, available in both parenteral and oral formulation, and it is like 200 mg 4 times a day. But alternatively, posaconazole delayed release tablets are also available, which are more effective. And we usually start with 300 mg every 12 hours on first day, and then 300 mg once daily. And it should be taken with the fatty diet to increase the absorption. So amphotericin B, how we started, there are 3 preparation available: injection amphotericin B deoxycholate, injection liposomal amphotericin B, and lipid complex. So plain amphotericin or conventional amphotericin, we give 1 to 1.5 mg per kg per day. Liposomal and amphotericin lipid complex should be given in 5 to 10 mg per kg per day. However, if there is an intracranial extension, we need to give only injection liposomal amphotericin B 10 mg per kg per day, which is only effective. Escalation therapy is usually not advised. You need to start upfront with the highest dose. So as slow escalation is not advised. So it should go on for 14 to 20 days, depending on severity and till clinical resolution, radiological stabilization. We used to also fill up this form daily. It's an amphotericin monitoring chart, where we used to write cumulative dose. We used to note the urea, create, sodium, potassium, and alternate day magnesium. Usually the cost is a deterrent here, because we know this. So because minimum of 3 gram we need to give. So if I talk about the amphotericin B, usually for 3 gram it costs around 18,000. For liposomal it costs around 3 lakhs, and for lipid soluble it costs around 1 lakh. So the cost is one of the deterrent, and it's really one of the major factor where it's cause delay in treatment. So other thing is antifungal azole. This is also costly, 10 to 20,000 syrup. The injection is around 13,000, and posaconazole tablet, which is sustained release, is around 1,200 per day. So why do we do surgery? It is for disease control and for infection control. At the same time, we need to send for fungal culture, for microbiological diagnosis and biopsy also. So early surgical debridement should be done in all patients. Some they report transcutaneous retrobulbar amphotericin B injections but most of the surgeons, they believe if there is extensive orbital involvement, orbital exentration with the only consultation with ophthalmology should be done if orbit is involved. So whichever bone is involved, so we need to remove that bone till we can see the bleeding in surgery. So that is a dictum. So we need to see, and all the bones and the soft tissue should be involved, which is necrotic. If I talk about the eye, exenteration of eye in cases of, this is indication with vision loss, total ophthalmoplegia, chemosis, and necrosis of orbital tissue. So if these 4 things we find, definitely we need to go ahead with this thing. However, loss of vision is not always the indication of exenteration, and ophthalmology consultation should be sought in this, and their advice we should take only their advice in this context. So what are the challenges of this entity is? One is high cost of evaluation and therapy. There are few reliable lab services in cities for mycology and histopathology. There are sharp increase in incidence when most resources are required for COVID care. We know that we are struggling with COVID, and now this mucor has come, and now we are struggling with the limited resources. The scarcity, cost, and toxicity of antifungal and injudicious use of steroid and potent antibiotic is one of the challenges. What is a further way? Mechanism of following guidelines on the use of steroid in COVID-19 should be, there was some mechanism following guidelines are there, but the state should fix some mechanism following these. There should be public awareness campaign for complication of uncontrolled diabetes and steroid therapy. There should be better labs of mycology and HP in most of the cities now. And there should be a clear-cut guidelines on antifungal therapy, and task force from government should be constituted to ensure these antifungal drugs, because these are very costly, and without government help, this disease cannot be treated. Thank you very much.
I think now Dr. Biswajit can start with his presentation, and I'll request the audience, if they have any questions, they can just raise their hands, or they can type in the chat box, because we have muted everyone. After the presentation, we will unmute the person who wants to ask the question. Dr. Biswajit, you can start.
Thank you, ma'am. I'll be speaking about basically microbiological diagnosis and preventive measures. So the fungal diagnosis in this mucormycosis include microscopic viewing, wet mount, KOH mount, Cacrophore white stain by fluorescence microscopy, periodic acid Kipf stain, gomery-methamine silver stain, and fish, that is fluorescent in situ hybridation, immunohistochemistry analysis, and culture. Okay. The serology, in the diagnostic part, we also have serology, which is based on ELI spot. The molecular techniques include the conventional PCR and RFLP, DNA sequencing real-time PCR. Fungal identification includes culture, which includes both micro and macro morphological aspects. The DNA sequencing, conventional PCR, again RFLP, real-time PCR, and MALDI-TOF. Sample collection, as far as the sample collection is concerned, as today morning I had discussed with Amit sir, tissue biopsy is always and will be always the gold standard. Second to it will be nasal swab. And after that, direct microscopy will be done by 10 to 20% of KOH with routine fungal stains, and including also fluorescent stains such as Cacrophore white. Culture will be done on SDA. Molecular analysis can be done by PCR. There are certain biomarkers which are needed to rule out other fungal infections such as aspergillosis, and they include beta-D-glucan and galactomannan. Coming to the one aspect that was discussed by Amit sir, that is diagnosis as soon as possible. That aspect that can be really helped by the DNA, I mean PCR. And coming to the sensitivity pattern, that aspect can be helped by microbial dilation, both of which are not there in our institute right now. And myself and Dr. Amba were really trying hard, and we discussed the matter with DHS sir also in the morning, and we'll be pursuing that and hope that we can bring it as soon as possible. And as to the aspect as to why it is important, detection of the circulating DNA by means of quantitative PCR, which will target the 18S rDNA from serum. It can be done from blood sample. It will help in early distinction with invasive aspergillosis, which is important for antifungal selection because the antifungal for aspergillosis is different from that of mucormycosis. The underlying conditions of both the infection, that is aspergillosis and mucormycosis, are similar, and the imaging findings also specifically do not designate separate mucormycosis from that of aspergillosis. Considering these facts, molecular diagnosis is really important. Antigens such as galactomannan and beta-D-glucan provides not much help, and the species which are responsible for 90% are Rhizophus, Rhizomuca, Lichthymia, and Muca. The 1 to 5% other species are also responsible, such as Cunninghamella, Apomyces, Saccharinaceae, and Coccuromyces. Now coming to the preventive measures of mucormycosis, there are certain do's and don'ts. The do's include control hyperglycemia, use steroid judiciously, as already mentioned by Amit sir, use antibiotics and antifungal judiciously. The don'ts are do not miss warning signs and symptoms. Do not lose the crucial time to initiate the treatment for mucormycosis based on clinical features. And certainly you must send the sample for quick diagnosis. Do not consider all cases with blocked nose as cases of bacterial sinusitis, particularly in high-risk individual, and get it thoroughly investigated. Do not hesitate to seek aggressive investigation such as appropriate KOH staining, microscopy, culture, MALDI-TOF for detecting the fungal etiology. And in case of COVID-19 patient, certain other guidelines are to be also followed. Use of steroid judiciously. Importance should be given to the correct timing, correct dose, and correct formulation also. And better control of sugar level, use of antifungal and antibiotics judiciously. And there should be a SOP for strict adherence to use of humidifiers. And that is, we should always use distilled water or sterile water. We should never use unboiled tap water or mineral water. We should fill up about 10 mm below the maximum fill line. The water level should not be allowed to pass below the maximum fill line. Water level should be checked twice daily and topped up when required. Water in the humidifier should be changed daily basis. Humidifier should be washed in mild soap water, rinsed with clean water and dried in air before reuse. Once a week for the same patient and in between patient, all components of the humidifier should be soaked in mild antiseptic solution for 30 minutes and rinsed with clean water and dried in air. Now, how to prevent in COVID-19? Use of mask if you are visiting dusty construction sites. Wear shoes, long trousers, long sleeve shirts, gloves while handling soil, moss or manure. Maintain personal hygiene including scrub bath. The disease can be managed by controlling diabetes, discontinuing immunomodulating drugs, reducing the dose of the steroids, and extensive surgical debridement should be done in order to remove all the necrotic material as per the advisory. These are my references. Thank you.
Thank you, Dr. Vishwajit and Dr. Amit for the presentation. I think it was very crisp and it was very clear. So we still have 2 minutes. So I will request anybody if they are having any questions. Okay, Doctor, I think there is one question there. You can just take the question. It's written in the chat box. Meanwhile, I'll unmute the speaker. Dr. Amit, can you take the question which is there in the chat box? I think
the question is there any role of local infiltration of amphotericin B? So there are some reports, only few articles, case series are available on this, but actually there is no proper trial or anything which is available which says that it actually is helpful. So but actually the only key is proper key is aggressive surgical debridement and amphotericin B. Without that, local infiltration of amphotericin B will not work. So if we think that because drug is scarcely available and we can just get the results with the infiltration, that is not possible. Yeah, with the proper amphotericin surgery, infiltration will work.
Hello, I would just like to add one thing. Hello, am I audible?
Yes, yes.
Yes, sir.
Yeah. I just wanted to add something like regarding hospital linen, one of the causative agent you had said. So laundry is doing a very good job that all the hospital linens, they are being soaked in 1% hypo solution, and then only it's being processed. So I would just like to thank the laundry, like they're doing a good service. So I mean, laundry part, it's being taken care of very well in a hospital.
Another question that the sinuses, can we use betadine to give lavage? If yes, then what concentration? So it is effective against, it has been found that betadine is effective against some fungal spores, but most of the research which is done, actually betadine you can do, means there is nothing we can say that it cannot be done, but there is no study which can say that it is really effective. Yeah, there are posaconazole prophylaxis in case of high risk. There are few institutes which are following this protocol. Like if there is a hematological malignancy or if it is there is a role of prophylaxis by posaconazole, and few institutes are doing it. But there is no large series which establish it.
I have unmuted you, ma'am. There is one more hand raised. I can see. We can take that question. I have unmuted you, ma'am. You can please ask your question. Hello. I think.
So one question is, without antifungal, surgery alone is how effective and what prognosis will be tell attendant? So surgery is just to remove the necrotic part. It is just to remove that and open up the spaces and tissue spaces by which the thrombotic vessels just open up and amphotericin can go there and act. But without amphotericin, actually surgery because the only treatment is actually the treatment which kills the fungal spore is amphotericin. Surgery is just removing the necrotic bone. It is removing the aspect of septicemia, sepsis, and opening up the spaces so that amphotericin B can go more into the spaces where actually there is a blood supply. So that is a Satya ma'am question. And how to disinfect, yeah. So it is same thing, means there is no specific sterilization method for nasal endoscope, but actually the time duration from 20 minutes to 1 hour, they say. So at least it should be there for 1 to 2 hours in glutaldehyde. Is there any role of voriconazole in prophylaxis for mucormycosis? No. Please, voriconazole, if you give voriconazole, thinking about mucormycosis, there are reports, multiple reports available where in ICU there is a local increase of mucormycosis when you give voriconazole. So voriconazole, if you are sure that you do galactomannan study, you know that it's aspergillus, then only give. If you are suspecting that it is actually might be mucor, it will grow with your voriconazole. So no. Any role of methylene blue, if at all? So I again there are a lot of things happening now. So a lot of things are doing, but actually we need to go evidence-based. Now evidence is not suggesting it. So there is a limited evidence. People are doing it, but actually, yeah, I'm still in the favor of this, that these kind of things should happen, and it should happen in a proper scientific methodology to prove it. But till now, there is no proven scientific evidence, proper evidence, level 1 or 2 evidence for this using of this.
Sir, I'll take the next one, sir.
Yeah.
Actually, ma'am has questioned, it is not easy to diagnose. Why did you speak of sophisticated tests? Ma'am, frankly speaking, the KOH mount and Caclopho white stain, if we find the hyphae, then it is okay, fine, we get it, the hyphae, and we just say to it that, okay, fine, we are getting mucor or isophus. But the problem, when I spoke of the sophisticated test, ma'am, I spoke of certain serological investigation. They were meant to rule out aspergillosis. Because, ma'am, the treatment for aspergillosis is different, and for mucor, it is different. Number one point, ma'am. Number second point, ma'am, I spoke of the molecular diagnosis because in the present scenario and where the guideline says, the most important part is as soon as you diagnose. Coming to that aspect, ma'am, when we do not find any finding on the microscopy by KOH mount or Caclopho white stain, we resort to the only thing that is left in a hand is culture, which might take at least 4 to 5 days or 1 week. In between that, ma'am, we could go in for the conventional PCR for quantitative estimation of the mucor infection, which in turn will help the clinician for better management of the patient. Then I spoke of, madam, antifungal sensitivity testing. Antifungal sensitivity testing I spoke of because, ma'am, in many cases, even resistance to amphotericin has been set in. And that's one of the biggest reason as to why, madam, if we also do antifungal susceptibility testing by microbot dilution, we'll be able to help the clinician in better clinical management of the patients. Thank you.
I would like to add one this point that it is very important what Dr. Vishnu said.
I think we can take one last question.
Is there any role of tincture benzoin stimulation? So I'm not sure about this, and I don't think so. What would be the mechanism by which it would be helpful? I don't know. Yeah, I have not come across any article also showing benefit of it.
I didn't get you, sir.
No, I'm just saying that there is one question. Is there any role of tincture benzoin stimulation?
Okay, sir.
So I'm just saying that I have not come across any this thing mentioned in the standard textbook or any article. Maybe the Vimlesh Sharma, if he's aware, maybe they can share it. But I don't know how will it help. I don't understand it also. What would be the evidence of it? But one thing I just would like to say on Dr. Vaishwajit's answer, that it is very important to know that it's aspergillus or mucor. Because if we don't know and we give voriconazole thinking that it's aspergillus, it will lead to more growth of mucor. So that we need to just remember.
Thank you, Dr. Amit and Dr. Biswajit. I think it was a wonderful session today because and a lot of queries were discussed. And I just wanted to add one thing, because recently reports are there that voriconazole is causing precipitation of mucormycosis. Probably the reason can be that it is usually voriconazole is a broad spectrum antibiotic, but it is not effective against mucor. So I think selectively it is giving the opportunity to mucormycosis to grow, and it is suppressing all the other fungus. So probably this might be the reason why there is a precipitation of mucormycosis with voriconazole therapy. And
that one article where they say there is some epigenetic changes also, which helps in propagation of this mucor. So
okay,
something.
So I think we can wind today's session because we are already running short of time. It's nearly 7:40. Thank you, Dr. Amit and Dr. Biswajit, and thank you all for joining us today. Thank you, everyone. Good evening.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Okay, thank you.